Today I'm going to be covering the topic of crash inductions, which basically is another term for rapid sequence inductions, and hopefully crashing is something we can avoid during the process. I want you to think about a patient that you've been called to the ward to assess, who's had a cesarean section under spinal anesthesia for preeclampsia and who has now gone into pulmonary edema. She's hypoxic. Her oxygen saturations are 76% on face mask oxygen. She's breathing at 42 breaths a minute and she is sweating, and the blood pressure is maintained, but the heart rate is 132. You put on a non-rebreather mask, elevate the head of the bed, and you stop the intravenous fluids. Her oxygen saturations improved to 86% and her breath rate is now 36. But when you phone the referral hospital, they would like you to intubate the patient prior to transfer. And you now need to proceed with a rapid sequence induction. And I want you to think about how you would go about performing that rapid sequence induction. The background to rapid sequence induction is that it was first described in 1961 by Selleck, and there have been a number of modifications to that original description. The primary reason for a rapid sequence induction then and now is to prevent aspiration of the gastric contents into the lungs. And in Selleck's day, they would actually insert a nasogastric tube before the intubation, empty the stomach, and then remove that nasogastric tube. They would also do it in a head down position in order to theoretically reduce this risk of regurgitant fluid going into the lungs. Now, since then, there have been a number of common modifications. We generally omit the placement of the nasogastric tube, or if it's in, we leave it in. We don't do them head down, we do them in a supine or ramped position. We titrate the dose of drugs sometimes instead of giving that full dose up front, as Selleck described. There are a number of other drugs we use now, so there are options to induce anesthesia. We sometimes substitute rocuronium for succinylmethonium, that's then called a modified rapid sequence. And there are times when we will either remove or omit the cricoid pressure depending on the patient's situation. So the absolutely classic rapid sequence induction is actually almost never practiced anymore. Remember that what we are trying to do is get airway control in a patient who has an aspiration risk. So this generally refers to patients who have got their airway reflexes maintained. So they're usually awake patients, or if their level of consciousness is down, they've still got their airway reflexes. And we are trying to get the endotracheal tube in quite fast after having induced anesthesia to prevent that aspiration risk. And the rapid sequence refers to that phase of having given the drugs, you rapidly put the patient to sleep, paralyze, and insert the tube. It doesn't refer to the process outside of that sequence. So you don't have to be running around necessarily. If the patient is stable enough to give you time to prepare, that period should be cautious. Now, inherent in that process is cricoid pressure, so I'm just going to deal with that quickly. Cricoid pressure is the application of force to the cricoid cartilage of the patient, as you can see in the picture, and it's that first cartilage below the tracheal ring. And the rationale is that the upper esophagus is occluded by being compressed between the trachea and the cervical vertebra, which prevents passive reflux of gastric contents and the subsequent development of aspiration pneumonitis. And that's where the cricoid ring is, and you need to identify that before you start, and your assistant needs to identify what that is and actually show you where they're going to press. Now, your assistant is going to need to, while the patient's awake, apply 10 newtons of force between the thumb and the index finger, and once consciousness is lost, 30 newtons of force. And it's actually not common for us to know what 10 newtons is or 30 newtons is. Now, 10 newtons is about 1 kilogram of pressure, 30 about 3 kilograms of pressure. And so before you start, you need to make sure that your assistant knows what this is and how hard they're going to press. 3 kilograms of force is uncomfortable for awake patients, so that's why you press with less, and then you increase the pressure once the patient's asleep. And you keep that pressure going, it's maintained, until the endotracheal tube placement is confirmed and you're asked to release it. Cricoid pressure should be reduced or released if the laryngoscopy is difficult and the person performing laryngoscopy says you must release it, or if vomiting occurs. And that's not regurgitation, that's active vomiting, which implies the patient is not paralyzed. And if they start vomiting, you have to remove the cricoid pressure because there's a chance of esophageal rupture if you maintain it. Now, mistakes happen when we rush. And rushing means we fail to examine the patient, we fail to prepare properly, we don't get the right people in, and we do the intubation potentially in the wrong place. So if you can, you need to find ways to slow down, think, make sure you've got everything in place, and discuss a plan. Now, the Swiss cheese model of error tells us that when a number of small errors line up, you can have a major error or a catastrophe. But with intubation, it's more like it's the Swiss cheese model of success. You need to get all those holes lined up. So you need to do a number of things right sequentially. And any one of those things, if you forget to do them, is likely to lead to failure or to morbidity or mortality. And those things are things like you need to position the patient correctly. You need to pre-oxygenate well. You need to make sure you've got suctioning and you use it if you need it. You need to have the right staff in the room. And there are a number of other things that I'm going to go through. The point that I want to make is that you can't afford for any one of these to not be in place when you do a rapid sequence. So the first thing you need to do is decide on what the time frame is for this intubation. You need to understand what the urgency is and see if you can stabilize and optimize your patient before you begin. And in the example that I gave you at the beginning, that patient, while needing intubation, you've got a bit of time. You can make sure the oxygen mask's on properly. You can sit the patient up. You might want to give some therapy such as Lasix. But you've got 15 minutes to prepare. You don't have to rush in. And that's an important thing to decide. Is this a peri-arrest situation or do I have time? If you've got time, you need to prepare the environment. And that relates to equipment, getting monitors, getting the right airway trolley, all of the things you will need, a ventilator once the patient's intubated. It means the right staff. If you're in the ward and the staff aren't familiar with intubation, do you have time to call the staff from the operating theatre who maybe do this more commonly? Maybe you don't have an anaesthetist necessarily, either the anaesthetist is busy or you don't have one in your hospital, but at least people that know when you ask for a piece of equipment, they know what to give, they know the sequence. And prepare the patient, explain to them what's going to happen, see if you can optimize their position. And then decide on the plan, what technique you're going to use, what drugs, what doses, which staff are going to have what roles, and where you're going to do it. Sometimes I've heard of instances where people would like anesthetic assistance and the anaesthetist is busy. Well, should you take the patient to theatre recovery so that if help is needed, it's close. Anaesthetists can sometimes step out of a theatre if you're next door. They can't if you're in a ward far away. And then make sure you've thought of your plan B. What happens if I can't intubate the patient? What is my plan then? In my own hospital and my emergency department, intubate a lot of patients, as one would expect. And before they're doing an intubation, they actually write up the plan on a whiteboard. And they make sure that everybody understands what they're going to do, what the roles of each person are, what the plan A, B, and C are, and they run through it as a team before they begin the intubation. Now, they're experienced intubators and they know how to intubate, and yet this is what they feel makes sure they don't have problems. So if the experienced people are doing this, it means that the beginner or the occasional intubator really needs to do this. So it's really worthwhile running through with the team what you are planning to do and what you're going to do if things don't go right. So they know, they're familiar with the instructions or the requests that you're going to make. And I do this before intubations, particularly in settings where people are not familiar with an intubation. So this is something worth thinking about. You don't have to have a whiteboard, but going through what's going to happen with the team is really important. Now, if you go back to that patient that I talked about earlier, there are a number of things that you can optimize before you start. Now, remember that patients in the ward are not in that theatre environment where everything is available. One of the things that's almost always wrong is the position. Whenever I come in to help with an intubation, the first thing that I do is optimize position. So this is something that you can get better, and I'm going to go through a slide on how to position just now. But make sure you are 100% happy with the position. This patient is sitting up because that's helping her lungs at the moment, but you would probably want to do this at 15 to 30 degrees of ramp with a pillow under the shoulders and an extra one under the head to push that head forward into the morning sniff position. Make sure that your oxygen delivery is sorted. So when you're doing the intubation, that will be through an ambu bag, the mask nice and tight fitting, the oxygen flow connected, the bag filling, making sure that that pre-oxygenation period is optimized. Make sure your IVI line is working. Test it before you start. I've seen too many rapid sequences where the test of whether the line is working is the induction agent and the paralysis. And then when the patient doesn't go to sleep, you think, okay, my line's not working. But now you've put the induction agent and the succinylmethonium into the patient's arm, and you don't know how much of that's going to be working, and it can cause problems. Things like propofol are not good to have in the subcutaneous tissue. So make sure that line's working. It's really, really important aspect, and if you're not sure, insert a new one. Give any therapy you think might help. In the patient that I mentioned earlier, I might have given some furosemide, some Lasix, to see if I can mobilize some fluid. Sometimes by the time you're ready to start, the patient no longer needs it. And examine the airway. Assess whether you're going to be able to do mask ventilation, laryngoscopy, and rescue airway. Think of the last intubation you did in the ward. Did you actually examine the airway before you started? It's a habit you've got to get into every time you do an intubation. This is another saying that I borrowed from the emergency department physicians. Do you stay and play or scoop and run? Every time you do an intubation in an unfamiliar setting, you need to think, do we need to do this here, or do we take the patient to where the equipment and the staff and the setting is more conducive to an intubation? Now this can be a tough call because moving patients is hazardous. You're going to move them, you have to keep them on oxygen. If things go wrong during the move, it can be a problem, but you must at least make that decision. Remember that once you've intubated the patient, more than likely you're going to have to move the patient anyway. So do you want to move with the tube in or with the tube out? And the more difficult the airway is likely to be, the more I'm inclined to take patients to where I'm familiar with the environment and I've got the equipment that I need. So it's a decision that you need to consciously think about. You obviously need to check your airway trolley. It's unlikely to look like this in a ward, but you need a working laryngoscope, different sized endotracheal tubes, Guedel airways, supraglottic airway device. You need things like McGill's, suctioning. You must check this, and you must have this in the ward. If you don't, it must be fetched. Now, if you want to remember how to check an airway trolley, there's a short video on the channel. It's just 5 minutes. It'll take you through the 5 plastics and the 5 metals. Go through that at some point and make sure that you know how to check an airway trolley, because if you leave even one item off, it's invariably going to be the one that you need. Now this is an open book exam, medicine. You're allowed to cheat, you're allowed to bring in whatever you want. This is an emergency intubation checklist, and it comes from an article that was in the WIFSA tutorial of the week, which I will reference at the end. And what I want you to see here is that it's broken into how to prepare the patient, prepare the equipment, prepare for difficulty, and prepare the team. And having one of these available either on your phone or on the wall or on the airway trolley is a very good way just to make sure, all right, have we thought of everything? And I would encourage you to use something like this or similar. You are completely allowed to change these checklists, like remove perhaps video laryngoscope if you don't have one, but put on this list the things that you want to happen and use it to check so that you don't forget something obvious. Coming back to positioning, if you find a patient lying in their bed in the ward, this is likely the position they're in, supine. And you'll see that in order to intubate, you've now got to go around a right angle. And it's very difficult to intubate in this position. Any one of us will struggle in all but the easiest airways if they're in this position. So put them in the morning sniff position. So here we've used pillows to do that. You'll see the mastoid process is in line with the sternum, and you can see that nice long thyromental distance. Now with that head slightly extended, you can look at the view that arrow is pointing in the way that you're going to look. And it's much easier to then see around the corner. It also moves the airway posteriorly so that you can see it with the laryngoscope. And you can do that with an operating theatre bed, but because you're likely to be in the ward for these, probably better if you learn to do this with blankets or with a pillow. The next thing to talk about is which induction agent are you going to use. And generally you've got 5 to choose from. The first is propofol. Remember that propofol 2 to 3 milligrams per kilogram in adults is commonly used. It gives excellent intubation conditions, but it's the one that causes the most hemodynamic compromise. So it tends to drop the blood pressure quite a lot. So in the elderly patient or a hypovolemic patient, you either need to drastically reduce the dose, something like 0.5 to a milligram per kilogram is often sufficient. You need to give it time to take effect because of the lower cardiac outputs. And probably this is a drug that you want to not use if you're not experienced with its use in this setting. Etomidate is another one that's commonly used. It's much better hemodynamically, doesn't cause as much drop to the blood pressure, although it does cause adrenal suppression, so it's starting to go out of favor and it's less commonly available, but definitely an acceptable drug to use. Ketamine is probably the most commonly used in the pre-hospital setting and also in district hospitals where people are unfamiliar with anesthetic drugs. 1 to 2 milligrams per kilogram. It tends to raise the blood pressure and the heart rate, except in a very, very critically ill patient. The problem with it, and in fact with etomidate as well, is that you must have muscle relaxation in order to intubate with it. It doesn't give you good intubating conditions on its own. Also causes increased secretions, so some people pre-medicate with either glycopyrrolate or atropine, but not a bad drug to choose if you're only going to be familiar with one drug. Thiopentone is what we originally used to use. It's now very hard to get hold of. It gives excellent intubating conditions, tends to drop the blood pressure somewhere between propofol and etomidate, but not used so much anymore simply because of availability. And finally, midazolam, otherwise known as Dormicum. And I want to just mention something about midazolam because this seems to be the drug that people that are very unfamiliar with intubations fall back on. They give a high dose of midazolam and no muscle relaxation. And I think what they're hoping to do here is keep the patient breathing so that if they can't get the tube in, at least the patient is breathing. Now, that has a sort of logic to it, but I've done intubations like this before, and it's, I think, one of the harder ways to intubate because the patient is not completely asleep. So you end up having to use force. It's a struggle. And so in the hands of the beginner anesthetist, you're now giving them the hardest conditions in which to intubate. So for me, I reserve midazolam for the patient who's already obtunded, lower level of consciousness, and I'm really looking for amnesia here rather than a full anesthetic. I might use a bit of midazolam then with a muscle relaxant such as saxamethonium or rocuronium. And finally, remember the dose is not a fixed dose. Healthy patients get a full dose, unhealthy patients get a half dose, and critically ill patients get something like a quarter dose. If I've got a critically ill patient, I might use 1 or 2 mils of propofol, 10 to 20 milligrams, and that can be plenty. So more and more in these critically ill patients, we are titrating the dose of the drug in. We wait to see the patient to go to sleep, and then we give the muscle relaxant, which is a form of a modification of the rapid sequence induction. So you're going to give the induction agent, and then you're going to follow it with a muscle relaxant. So in this instance, I've chosen ketamine, and we're going to follow it with saxamethonium, 1 milligram per kilogram, remembering the contraindications to saxamethonium. And the big ones are burns patients or prolonged immobility, susceptibility to malignant hypothermia, or hyperkalemia. Those are the main ones that I think of when I'm using saxamethonium. Can you use rocuronium? Yes, it is an acceptable substitute. You give it as a milligram per kilogram when you're giving it in a modified rapid sequence dose. That will work slightly slower than saxamethonium, usually 45 seconds to 60 seconds. So you will often bridge that gap by gently mask ventilating. But remember that rocuronium that you use in that dose is going to work for almost an hour. So you are committed. You can't, like in the case of saxamethonium, wait 5 to 10 minutes and wake the patient up. You're looking at an hour. Now, in some settings, they've got reversal for rocuronium. That's called Sugamidex. Very expensive drug and only really available in private settings in South Africa. So rocuronium is becoming more and more popular, especially where you've got the reversal. And then just remember, if you're dealing with that hypotensive patient, it is permissible to start an adrenaline infusion while you're doing this. Not a bad idea at all, because when you give those induction agents, the blood pressure is going to drop. So running an adrenaline infusion, even at very low dose, is a good idea because it's very easy just to increase the dose if you need it. So this is the classic rapid sequence. You position the patient supine or head up. You pre-oxygenate for 3 to 4 minutes to get an end tidal oxygen of between 80 and 90%, or you use 8 vital capacity breaths, but pre-oxygenate well, very, very important. You administer your drugs in rapid sequence, induction agent, followed by succinylcholine, and you don't use an opioid for traditional rapid sequence. You've got cricoid pressure at 10 newtons of force, 1 kilogram, before the drugs are given, and once the patient is asleep, you increase that to 30 newtons or 3 kilograms of force. You secure the endotracheal tube, ideally with the first pass intubation, which means your most experienced intubator usually is the one doing this. You inflate the cuff, confirm position in a number of ways, misting of the tube, chest rise, auscultation of the chest, and if you've got it, capnography. And then and only then do you release the cricoid pressure. That's the classical rapid sequence induction. Remember, when you're intubating, I've put a link there to a really nice resource at airwayjedi.com, which will walk you through how to intubate. Keep your back straight, don't rotate your wrist, and lift up, and away. So you're pulling it away from yourself rather than rotating that wrist towards yourself. We've got a separate video on that you're welcome to go and watch. And remember that cricoid pressure can be transformed into a burp maneuver, which is that person giving the cricoid presses backward, upward, and rightward. So essentially what they're doing is they're pushing the airway more posteriorly and into your view. So they push it towards the right, and so that you can see it. Remember, you've swept the tongue to the left. And I will often put my hand on the hand of the person doing the cricoid pressure and move the larynx to where I want it and say hold it there and then intubate it. It's a very useful maneuver. It can take an airway that looks like this and transform it into this. And it really does make things easier, so use that maneuver. So to run you very quickly through this, and this is on a separate video, insert the blade on the right hand side of the mouth, sweep the tongue to the left as in the picture, look for the epiglottis. At this point you are not looking for vocal cords, you're looking for the epiglottis. Put the tip of the laryngoscope at the base of the epiglottis, which is called the vallecula, and you notice that at this point you still haven't lifted the laryngoscope. You are still just looking for the epiglottis and getting the tip of the laryngoscope in the right position. It's at that point that you lift up and away. You may need the burp maneuver to bring the larynx into view, and then watch the endotracheal tube go through the cords. Don't lose sight of the cords when that tube goes through. It often means you sort of come in from the right and you twist the tube in. You don't want to lose sight of the cords because that's when it slips below the arachnoid cartilages and you end up intubating the esophagus. Alright, so here, this is someone intubating. They've put the laryngoscope in, probably a little central, and should have done a tongue sweep. They're now looking for the epiglottis. There it is. Now you can see the epiglottis, and that person is trying to get the laryngoscope blade at the base of the epiglottis, which as you can see is called the vallecula. But then this person pushes it too far, and you'll see them go past the epiglottis. This is a common error that people make, and even though you can see the cords, this is not what you want. You want to pull it back like that person has done, and now you're in the right place and you can lift that up. Once you get that epiglottis nice and lifted, you can see the vocal cords. This is now the best view that you can get, and you can see the glottis between them. Now you must make sure that that tube that comes through doesn't obscure your vision like they've done there. Now you can see that you've got a nice view of it going through the cords. When you've struggled, you will always push the tube too deep, so make sure that you adjust the depth under vision. This is the best time to do it. You can see that the second line has now come out of the vocal cords. That's one way of telling how deep your tube should be. You get it in the right place, and then you can inflate the cuff, confirm the position, release the cricoid pressure, and strap the tube. Remember, there are difficult intubation guidelines. The Difficult Airway Society has one, just to remind you that if you can't intubate, the goal is ventilation, not intubation. So remember to mask ventilate, use a supraglottic airway device, and if necessary, proceed to a surgical airway. Some of the modifications we use routinely intubate patients with a ramp or head up. This is basically 15 to 30 degrees. I think it makes the view easier, and it's good for patients' lungs when you're pre-oxygenating them. I commonly mask ventilate between giving the induction agent and the onset of the succinylmethonium, so that's about a 30-second period. This is gentle mask ventilation below a pressure of 15 to 20 centimeters of water, and it's indicated in patients who have difficult airway or are obese or are hypoxic or have reduced functional residual capacity, which, if you think about it, is just about most of the patients you end up doing rapid sequences in. So I routinely do this, and I find it makes everything much smoother. The key is when the fasciculations are done is to start intubating even if you haven't been able to mask ventilate, and also not to mask ventilate at high pressures, which leads to gastric insufflation and potentially regurgitation. And finally, we abandon cricoid at a lower threshold than we did previously. If it's messing up your laryngoscopy, abandon it, or for those other reasons we discussed earlier. And those are the routine modifications that people are making nowadays. Finally, this is a great summary of rapid sequence induction in tutorial of the week. If you search for rapid sequence induction and for the anesthesia tutorial of the week, this will come up. It's a free download, and it's worth a read just to cement the principles that I've talked about today. Thank you very much.